Hold on. Okay, it's recording now. How are you?
I'm good. How are you?
I'm fine. Thank you for having this conversation for me. I really appreciate it.
Are you able to hear me okay?
Yes. What about you?
Okay. Yeah, perfect.
Okay, good. Just okay. I want to start with myths about drugs, and you're discussing marijuana in the progress, I think, recently, and even when I talk about drugs, people comment to me that marijuana is a gateway drug. Can you elaborate why this is not true?
It all depends what people mean when they say gateway drug. Oftentimes, people mean that marijuana leads to harder drugs, and that's not true. So if that's what they mean, that's not true because it's true on the one hand that when we think of harder drugs, if there can be something called harder drugs. By the way, I don't really believe in that distinction. There are we can talk about reasons why and whatnot, but the bottom line is that when we think about marijuana um, and leading to those other harder drugs, the vast majority of people who use heroin, cocaine, if that's what you mean by harder drugs, yeah, it's true. They have used marijuana before using those harder drugs. If you stop there, then you might say, yeah, it's a gateway drug. But then when you look at the fact that the vast majority of marijuana smokers don't go on to use those drugs, then it's not a gateway drug. So it's illogical to make that sort of statement. It would be like saying the last three presidents of the United States all used marijuana before becoming president. Therefore,
Mhm.
marijuana is a gateway drug to the White House.
That is a
It's
very excellent argument.
yeah, it's not logical.
What about these those users that moved from marijuana to crack and cocaine or other harmful drugs? They did not start with alcohol or tobacco, and people just focus on criticize marijuana and forget that there was a prior drug before.
Yeah, that's another great point. Of course, they all may have used alcohol or tobacco before, and then many of them will have drank water before and drank milk or had a fruit. So, it's like when you try, but when we think about it seriously, more of those people have done things like engaged in petty crime than those folks who use marijuana. So you say, well, petty crime might be a gateway drug, a gateway to harder drug. You can think of a number of sort of behaviors associated with people who go on to use heroin and call those behaviors gateway. But
Mhm.
it's a real complicated, difficult conclusion to draw, and without being illogical.
When I set up this interview with you 2 weeks ago, I didn't know that I would receive a magazine over here in Brazil. Uh, with the cover page is about crack, and it's something that the drug reached the medium class of the Rio de Janeiro and is responsible for 10% of internation in particular clinics for chemical dependence. And there's 5 pages, 4 pages of stories of different people that cracks transform their lives. Something that the guy was stopped in the UTI for because of the crack, which is, I'm sorry, I'm not speaking correctly. It's the emergency room and the people that got in the emergency room in the hospital. In 7 months, I become people that lives in the street. Then another person says, in my delirium, I speak with Barack Obama. So there's a full of narratives and personal anecdotes that you mentioned in your book very clearly. And one of the things that I wanted to question is you mentioned very clearly in the book the distinction between crack and cocaine, and they are based on almost the same drug. So what's really the difference between crack and cocaine?
Pharmacologically, there is no difference. So when we look at powder cocaine, then we look at crack cocaine. Both of them, the major thing that people are seeking when they use cocaine is the cocaine base. That's the chemical structure, the base. Powder cocaine contains not only the base, but it also contains a hydrochloride salt that
Mm-hmm.
makes it stable. It decreases the likelihood that you can smoke it, for example. If you want to smoke it, you have to remove the hydrochloride portion of salt. That's the only difference. That hydrochloride portion does not contribute to the biological effect of cocaine. And so people describe the difference between crack cocaine and powder cocaine. What they're really describing is the difference between the way that the drugs are taken. So if you smoke a drug versus snorting a drug, the onset of effects are faster, more intense when you smoke it than when you snort it. And that's what people are explaining or really describing.
Mm-hmm.
But you can dissolve powder cocaine in something like water, shoot it in your veins, and get the same intensity of effects as you do from smoking the crack. The same effects. They're the same drug.
But the fact that when someone uses that way of reaching the drug the brain more faster, isn't more addictive.
Well, think about this. There are people who smoke marijuana, and there are people who use marijuana in their brownies and their cookies.
Mm-hmm. Yeah, I know.
Do we pass laws to
No,
say
of course not.
it's ridiculous?
Uh-huh.
That's so your point about it being more addictive. Again, it's not even real. That's one of the arguments that some scientists have made, but there is no drug that we punish as a result of the route of administration, besides crack cocaine and powder. It's the only drugs that we make that distinction. And we made that distinction in the United States primarily because crack cocaine was associated with poor black people. People will tell you all kind of other narratives like it was the violence associated with crack cocaine. That's why we passed the difference. That's why we punished crack cocaine so harshly. It was not the reason. The main reason, if we're honest, is because who the drug is associated with. Because when we look at powder cocaine in the United States in the 1980s, there was no drug that produced more violence in the trade than powder cocaine. But no one passed new laws because the people who were engaged in the trade were not black people. They were primarily white folks in the United States. And so people are not honest about this.
Thank you very much. In this addiction issue, you have mentioned very often that one dose of a drug is not enough to get a person addicted. So, can you explain this? I think this is a myth.
Yeah. So, drug addiction, by definition, means that the person has engaged in this behavior that disrupts their psychosocial functioning, their jobs, their family life, all of these things. It disrupts their functioning at the repeated times. So you have to have disruptions on multiple occasions. So if you use a drug once and you have disruptions once, that's not addiction. Addiction requires work. And so when people say one hit of a drug causes someone to be addicted, there's not one hit of anything that causes anybody to become addicted. That's just, if someone says that, it's just pure hyperbole, and people are just trying to get some emotional rise out of the listener.
What about the percentage of users of certain drugs? I wanted to make some sort of comparison over here. Even go for legal drugs. For example, tobacco and how addictive it is. How many people that use tobacco got addicted? And let's make this comparison.
Yeah, so we think about tobacco. Tobacco is the drug that we say causes the most amount of addiction, because 1 in 3 users of tobacco, or a third of tobacco users, will become addicted. When you look at alcohol, about 15% of the people who use alcohol will become addicted. Something like marijuana, about 10%, less than 10% will become addicted.
So we can say that, for example, marijuana is less addictive than alcohol.
We certainly can say that from the statistic, the epidemiological statistics. We certainly can say that. But now, one of the things that we also have to think about too is legal status of a drug. Alcohol, tobacco are legal, whereas marijuana is illegal. So it's a difficult comparison to make. But even with that situation, it would be hard to imagine a third of the people who smoke marijuana will become addicted. I would not predict that, even if we made marijuana more available, simply because how people use marijuana is slightly different than how they use tobacco.
All right. What about the other drugs? For example, heroin. How many people got real addictive of heroin?
So heroin, about a quarter of the people, 25% of the people use heroin will become addicted. With cocaine, it ranges from about 15% to 20% will become addicted. So it all depends.
And crack could be the same of cocaine. I know they're the same drug.
Crack fits in the 15 to 20%. Yes.
Okay. Yeah, I agree with you about the question that you about decriminalization of drugs. One interview that you made recently, I'm not sure recently, but for Brazilian magazine, you make the comparison of alcohol with a guy that takes one cup of wine a day and we do not consider him addicted. And I started to think about that, and I started to predicting that people, if I change the wine cup at night from a guy and change it to a legal drug, people would automatically see this guy as an addict. For my surprise, some people do not say this as an addict, but I got some responses, immediate response saying the guy is an addict, because people believe that the harm of the drug, of illegal drug, is more intense, so we can classify the guy as an addict. I think that the argument you made is very clarifying and very interesting to make.
Yeah, that's part of the problem. People can't get past the legal status of a drug. They think somehow that drugs are illegal or legal based on some rational pharmacological reasoning. Most of these drugs are not legal based on some rational, logical, pharmacological reasoning. They're based mainly on sociological reasoning rather than pharmacological.
Yeah. For example, motivated by your book, I started to looking more at this issue about drugs, and I got the book of another psychopharmacologist, David Nutt. You think you know who he is?
Yes.
Drugs Without Hot Hair. I think the book is entertaining, and he mentioned that in one of his studies in 2010, he classified alcohol as the most harmful drug, and to make this comparison with that we are looking free to another drugs and giving alcohol. And something that he also suggests, something that we did with tobacco years ago, to try to make people consume tobacco in the free areas less, to do something like with tobacco. Do you agree with some sort of these measures?
Well, certainly one of the, by the way, I really dig what David does. I'm a fan of his work.
Mm-hmm.
And I'm also a fan of his sort of advocacy, and he's trying to educate the public. So I admire what he does.
Mm-hmm.
And what he's trying to do, I think, is trying to help the public understand that when we think about whether or not a drug is toxic, we can look at multiple measures. And on one measure, alcohol may be seen as the most toxic drug. For example, when we think about withdrawing from a drug, when people abruptly stop long-term use of a drug, alcohol is clearly the most dangerous of the drugs that we're concerned about, because you can actually die from an alcohol withdrawal. You can't die from a heroin withdrawal. You can't die from a cocaine, crack withdrawal. You can't die from a tobacco or marijuana withdrawal, but you can die from an alcohol withdrawal. So when you look at, it all depends on what measure you're looking at, and when you're trying to determine the toxicity, a potential toxicity of a drug. And I think that's what he's trying to get society to do, to understand that it depends on what's the.
Yeah. About the behavior of addicted people. Media portrays that, as you say, very different than they actually are. How this percentage of the people who use drugs become addictive? For example, we can choose heroin. Really behaves. They experience cravings. They got violent. In this magazine that I showed to you about crack, they say that they become zombies. But and even people told me, look, they become zombies. I know because I can see it. But hold on a second. You can mix some factors over there, because these guys live in the street. These guys don't have anything to eat, don't have a job. So maybe what you call a zombie, he's been a zombie before. I don't know what you call a zombie, but maybe you confounding factors on your analysis. So please, can you elaborate how really addictive behaves?
Well, I think you just said it better than anybody, I think, could say, in that you're absolutely right. One of the things that people must first understand So I'm a psychologist as well, training, and so psychologists, of course, are experts in studying human behavior. But all of us humans, we all behave. So we all think that we are experts in understanding human behavior, and we are not. And that's part of the problem when you think about what anecdotal reports that people give you. They see somebody misbehaving in some way, and they know that person used a drug, crack cocaine or whatever drug. Therefore, that misbehavior is directly caused by that substance. No, there are multiple other factors that you have to consider. You have to consider the person's psychological history. You have to consider whether or not there's other drugs on board. You have to consider whether the person has slept, eaten, whether the person has had an interaction with someone who really angered them, and the person, the anger or behavior is justified. All of these sort of factors, people oftentimes fail to do once they understand that you use some vilified drug, and that's a problem. That's why anecdote alone are insufficient to really provide outstanding explanations of behavior.
Uh, you have done one of experiments that I think fascinating is about addictive, and you gave participants two choice and one drug and the other's amount of money, and you increase the amount of money. So what did you find in the experiment?
Yeah, so one of the things that people say about drug users, particularly drug addicts, if you will, that they can only respond, or they mainly only respond to their drug of choice. No matter what, if you give them an opportunity to hit a hit of their drug, they're going to take it over anything else. So we did similar experiments where we just had escalating amounts of money that we offered them. Other people have also done this. And what you find is that as you increase the monetary value, the amount of money, you decrease their choice to take the drug. They choose money instead, just like you and I would do. They behave rationally. People have indicated that drug addicts don't behave rationally. It's just simply not true.
Well, I want to now question about some uh, harms of the drug, some myths that people have been claiming. For example, you mentioned very often about methamphetamine and cognitive decline, and you have published a paper about it, a review. So, how does the evidence tell us about the harms? Let's focus on cognitive harms about methamphetamines. Just to
Yeah,
start.
when we think about methamphetamine, there are some serious potential harms. All of these drugs that we're talking about, there's serious potential harm. And that's the first lesson that people should really know. But the problem is, when you only emphasize the potential harms, people who have experienced these drugs and use these drugs know that there are other effects. Well, that's why they use them. And so they stop listening to you because you're only talking about these harms. So if we think about the methamphetamine harms, the ones that concern me, the major concern that I have with methamphetamine is that it it has some really good effect or powerful effects on your cardiovascular system, your heart rate, your blood pressure, increases blood pressure, increases heart rate. All of those sorts of things are not good for people who have a compromised cardiovascular system. They should not be taking large doses of amphetamines. Another thing that concerns me about amphetamines is that they so powerfully disrupt sleep. Sleep is an important biological function. Without sleep, you can have all kinds of physiological and psychological problems without any drugs on board. But sleep deprivation could cause all of these problems. So when people are taking amphetamines, I hope they are attentive to their sleep. Amphetamines disrupt food intake. Food, of course, we know is so critically important for the proper functioning of the body. We know those things. So if people are taking amphetamine, these are the real concerns that they need to be aware of, rather than those other sort of concerns that is often
Betrayed.
portrayed and also emphasized in the media and even in science by scientists. It's like when you emphasize those other things, people stop listening to you because they know that they don't, for example, have cognitive decline. Amphetamines are approved in order to enhance cognitive functioning, in order to treat attention deficit disorder. So the notion that the drug is causing all of these cognitive disruptions, it's just inconsistent. What this whole history of behavioral science that we have with these drugs. And we also emphasize how amphetamines causes tooth decay, all of these sorts of things. The likelihood of that is so low that it's not even worth talking about. But it has received so much attention in the popular press as well as the scientific literature, when the literature should be emphasizing cardiovascular effects, sleep, food intake, all of these sorts of things that are critically important for human functioning.
For example, another one that I think is quite often for lay people is saying that marijuana or cocaine kill neurocells, kill the neurons of your brain. There is any evidence of this kind?
So when we think about all of these psychoactive drugs at very large doses, alcohol, tobacco, name it, they can kill brain cells, yes. But those doses are so large, they would be so unpleasant to humans, they would not take those doses again after experiencing that effect if they survive it. So the doses are 20 times what a human needs to take, 40 times, 80 times what a human takes. And so, yeah, you certainly can get brain cell death with any of these drugs. Alcohol, tobacco, cocaine, methamphetamine, yeah, absolutely.
But with the normal dose, even long-term use cannot provoke the.
No, there's no evidence that even long-term use of doses within the range that humans take them,
Yeah.
produce neurotoxicity. I mean, think about this. These drugs have been with us throughout human history. And we think about the people who have used these drugs for some periods of time in their life, and then they go on to do productive things in life. For example, we have a president in the United States who certainly indulged in marijuana use, cocaine use, and wrote about it. There have been far more people than the president who have used these drugs when they were younger, and they still use them today. They go to their physician and get prescriptions, and they are being productive members of our society. So this is just hyperbole when people make these statements about the neurotoxicity. It certainly can happen, but the likelihood that it happens to people using within the dosing range that humans do is really low.
So, what the evidence tells us why people really got addicted to a specific drug? This is a hard question, I think it is.
That's a difficult question, and that's a question that science should be really focused on. So when we think, one of the things that science has recently focused on in answering that question, we've been looking for biological mechanisms to answer that question. And frankly, we have not found any that's compelling. So one must look at other things too, like things that we know. We know that if someone has a co-occurring psychiatric illness, depression, anxiety, schizophrenia, you name it, if they have a co-occurring psychiatric illness, it increases the likelihood of them becoming addicted. If, for example, addiction is a disease or an illness that is mainly characterized by not tempering your behavior in that domain of taking drugs. There are people who do not temper their behavior in a wide variety of domains. They just haven't learned the skills to do that. It increases the likelihood of them becoming addicted if they indulge in drug-taking behavior. Because taking a drug requires that the person be responsible, just like driving an automobile. You can't be a really irresponsible person driving an automobile. You might hurt yourself, you might hurt someone else. Drug taking is the same way. If you haven't learned those responsibility skills, it increases the likelihood of you becoming addicted. Also, if you don't have the studies that we've been doing where we offer people these alternatives like money, if you don't have many alternatives in your life that are better than drugs, it increases likelihood of you becoming addicted. All of these factors are critically important when we are trying to determine why someone became addicted versus someone else who did not. If you look at these factors, I think you might have some clues.
Yeah, you mentioned about biological mechanisms to get addicted, but media loves the dopamine hypothesis. It loves mentions about dopamine hypothesis, and in your book you say that dopamine hypothesis has some problems on it. Can you clarify just briefly why dopamine hypothesis is not as we even think?
Yeah. So, like when we think about the dopamine hypothesis, let's just talk about what it is first. The simplistic version is this: as you increase dopamine, drugs like cocaine, methamphetamine, all of these drugs, they increase dopamine, and that kind of increases pleasure. And so people say things like, "Oh, people are trying to increase their dopamine, and that's the dopamine. That's a critically important factor." And that was a theory, and that was an important theory because it helped us to organize various types of experiments, and we can test the hypothesis. It's nice, but that sort of theory and hypothesis came about in the 1960s when we had five or six neurotransmitters. We had identified five or six. Today we have more than 100, and the theory has not been appreciably updated. So we have learned a lot about the complexities of the brain in terms of how neurotransmitters interact with each other. So rather than just one neurotransmitter being fired at one time, there are multiple neurotransmitters that are fired together in order to produce effects. They are co-localized, sometimes in the same cell, all of these sorts of things. This theory does not have any sort of nuance that incorporates this new knowledge. And so the dopamine hypothesis, for me, is just too simple to explain this complicated behavior. But I think people should continue to look there. But we have some observable behavioral information that could actually help people right now. Does the person have a co-occurring disorder? Is the person responsible? Are there other alternatives in the person's environment? All of these things we can manipulate right now and help the person immediately. You can't help the person immediately when you have your dopamine hypothesis. How does that help the person struggling with drug addiction? It doesn't. It doesn't help anybody in treatment. It doesn't help them at any practical level. It's at the level now where scientists are just trying to figure it out. And we're not close if we're talking about dopamine.
Well, what about treatments, pharmacological treatments? You have published research about. Uh, I'm a medical scientist in some sense, so I really want to understand if a person wants to be treated, and we can offer some specific treatments. What is the best medications we can use for, let's say, cocaine addiction?
There are no approved medication for cocaine addiction. There are none. And I spent a large part of my career trying to develop medications that will help people with their cocaine addiction. And we were unsuccessful and have been unsuccessful in finding a medication that would work. Seems like the best medication for cocaine addiction is cocaine itself. I mean, that's how it is when we think of heroin addiction. Heroin is used in Switzerland and other places to treat heroin addiction, and it's used successfully. So when we think about treatment, this says a lot about why people are addicted. When we think about treatment, there are a variety of components that are necessary. Not only the drug, you got to make sure people have psychosocial support, therapy to make sure we figure out what's going on with their addiction. Do they have jobs? Do they have a social network? All of these kind of things are incorporated into the heroin program in Switzerland that's been successful in treating heroin addiction with heroin. They call it heroin assisted treatment. You can do a similar thing with cocaine, but you have to have all of these other auxiliary components in place. If you don't have those things in place, you can give any drug you like. It won't work because you have to really get at the bottom of why people are addicted.
So you're saying that the medication that might work in the future is just some part of the treatment. It's not the whole treatment. We have to
Yeah,
look. Okay. We have to look
absolutely.
into the whole thing, the whole picture of the guy or the person that's got addicted, and not just focus on the medication. Of course, we have to reach the right medications for each drug that the people's being addicted. But that's not the end. This is not the end of the path for treating.
No, no, no. You have to figure out why the person is addicted, and then you have to make sure you have all of these components in place. Therapy, talk therapy. You have to make sure they have social networks. All of these things that are important for humans. Human interactions, making sure that people have some sort of need, some value, and all of these things we talk less about.
About your opinion of decriminalization drugs versus legalization, why you stand with decriminalization and not make them legal right away? My question is because, well, if look like you have mentioned this interview, alcohol and tobacco, we know they are danger and they are legal. Uh, I understand the point of decriminalization because you don't want to make people in jail and make their life worse. So, but why not with this gap of
Yeah. So when we think about alcohol and tobacco, um, let's think about this. So of all these drugs we're talking about, the one that will probably kill you with the smallest amount of it is nicotine. That's in tobacco. So 50 milligrams of nicotine, for example, will probably that would kill half of us. Half of the people who take it, it will kill us. 50 milligrams of cocaine, 50 milligrams of heroin, you just have a nice buzz. You feel really nice, right? That's it. So when we think about the fact that so little of nicotine is required to kill people, and it's legal, why? Well, it's legal because we have societal structures. We have a societal combined education, a common education about nicotine, such that we know how to keep people safe with nicotine. One cigarette contains 1 milligram of nicotine. You have a pack of 20, that's about 20 milligrams or so. And so it requires the person to smoke multiple packs immediately to kill themselves. So we package the nicotine in a way that it substantially decreases the likelihood of someone getting harmed. All of this would have to be done for marijuana, for cocaine. We would have to figure out how to package it and educate people in a way to keep them safe. We have not done that. We don't have the social structures in place to do that as of yet. We certainly can. And so when I think of decriminalization, I think of it in part as an intermediary step to legalize or regulating it like we regulate alcohol and tobacco. But we have to work to put those social structures in place to keep people safe, because all of these drugs are potentially dangerous and they all can be used safely if we have these structures in place.
so? I make this question to you when we were in Brazil, but I wanted to make the question again. We both try to talk more about evidence-based thinking instead of faith-based thinking. Uh, and you have been, you write a book and have been gave lectures in several places. What do you think makes the change to bring people for faith-based thinking to evidence-based thinking? I know this is a hard question, but maybe you have found something that works better than others' approach.
That's a difficult one because, um, when we think about faith-based thinking, um, people, well, when you try and change people's view about something that they think they know, you are, in some cases, they feel threatened and insulted because they worked really hard to acquire this knowledge. And now you come along and you tell them that they're wrong.
Some sort of cognitive dissonance.
Yeah, and that's hard for people. And so the approach has to be, one that connects with them in some real meaningful way and also validates what they think. So on the one hand, you say, you know, I was just like you. I got fooled. They fooled me just like they fooled you. But here's how I saw it differently, and here's how you can see it differently. It's kind of simple, or this is how it worked. And that's how, so you have to make some connection with an audience, the people, in order to help move them along. Because if you don't, and sometimes we all get impatient because we don't have the time to make the connection, we say, no, the evidence show this, and you're wrong. And that usually doesn't work. But I understand people being impatient because they hope people would just follow evidence, but it doesn't work that way. So you have to make a connection with them, and you have to avoid talking to politicians as much as possible and talk to people. Because the politicians are usually a waste of anybody's time who's really trying to use evidence.
What do you think is a critical skill to be a good scientist?
A critical skill to be a good scientist is to always try to disprove your own hypothesis. If you are not doing that, you are subjected, or you increase the likelihood of you falling into dogma. You have to always try to design experiments to disprove your hypothesis.
Very, very good answer. What about the book High Price? You tried to put a lot of things together, memoir and a science book and a policy book. So what's this is my final question. What's your goal when you sit to write the book?
The goal was to communicate with the general public. I have been communicating with the scientific community, and I've learned that the scientific community is not progressive, and the scientific community has a different goal than the broader community. The scientific community's first goal is to keep their lab funded, and sometimes keeping your lab funded is inconsistent with the larger goals of society. So when we think about drug abuse research is mainly focused on the bad effects of drugs, because the major funder, the National Institute of Drug Abuse, they fund 90% of the world's research in this area. Their goal is to focus on the bad things that happen with drugs. So scientists are shaped by this goal, and that goal is inconsistent with society, the larger society. The larger society has the goal of being safe first. And so that goal is also within the context of people will use these drugs. And if people will use these drugs, what's the best information? Starting at that point to keep them safe. Scientists are not starting at that goal. Scientists start at the goal of don't use these drugs. So it's inconsistent. Those sort of subtleties people miss. And so I wanted to make sure I communicated this message to the public, so the public understood your goal and the scientist's goal who's talking to you is different. Your goal and the goal of the policeman who's talking to you is different. Your goal and the goal of the media person who's writing the story about drugs is different. Your goal and the politician goal is different. All of these things I try to point out in a way that people see that even though we may be speaking Portuguese, English, we're really not speaking the same language.
Dr. Hart, it's a pleasure interview. I would like to thank you for your time, for your attention, and kindness for making this happen. Thank you very much for your time.
Thank you, and I enjoyed it, and I hope to see you when I'm in Brazil next.
Yeah, me too. Thank you very much.
Okay, take care. Bye-bye.
Yeah, bye-bye.